Good afternoon, everyone. Warm greetings and welcome. My name is Professor Tricia Rose, and I'm the director of the Center for the Study of Race and Ethnicity in America at Brown University, CSREA. This event, Race and Public Health in America, is a collaboration between CSREA and the Office of the Provost and the Provost himself, Professor Rick Locke. Race and Public Health is actually part of an 8-part series called the Race and in America series, which is designed as an informal yet informed discussion series intended to elevate awareness of the substantial impacts of systemic racism across many facets of society. There are many of you registered. We're really delighted that you're here. This is the second of this 8-part series, and so registrants will receive further information regarding upcoming series webinars. But please make a note of the next event in the series, which is November 4th on race and social movements. Thank you very much for joining us. This is sure to be a spirited and informative discussion. And now I'd like to turn it over to my esteemed colleague, Dr. Ronald Aubert.
Thank you, Tricia. It is a great honor for me to be here today to moderate this panel of really giants in their respective disciplines. There have been many conferences and studies in the past that look at social factors, how they drive poor health outcomes. And despite that large growing body evidence of research, many scientists, policymakers, and others are reluctant to identify issues of structural racism and those sorts of factors as being the root cause of racial health inequities. I think COVID has sort of ripped the covers off of that. And even though we're not going to be talking about COVID specifically here, COVID is really about this topic. I mean, it helps illuminate some of the issues around race and public health in a way that I think was about as clear as we've had in the past. So without saying more, I'd like to introduce a really stellar panel of speakers that we have today. We're going to start with Professor Lundy Braun, who's a professor of medical sciences and Africana studies. In addition to that, Lundy is also affiliated with Center for the Study of Race and Ethnicity in America. And important, I wanted to point out that Lundy has really organized a beautiful series, the working group on race out of CSSJ here at Brown University. So without saying more, I want to start with Professor Lundy Braun.
Hello, everybody. First of all, I would just like to extend my sincere thank you to Professor Tricia Rose and Provost Rick Locke for the invitation to be a part of this esteemed panel. And I'm really thrilled to be part of the panel. I'm looking forward to a thoughtful discussion with other panelists and with members of the audience. I'm going to speak about public health and medicine, just a little preview, as a fairly unified biomedical unit because at the moment they inform each other. Although at various moments in history, they did differ quite substantially and certainly have somewhat different perspectives even today. The extreme elitism, as I think Ron was alluding to a little bit, of US medicine has been on full display over the last few days. But I don't want to focus on the kind of excess healthcare the elite gets. Rather, I want to think carefully about the utter lack or inadequate healthcare for many, especially Black patients, that has led to such poor health. So the question I want to address is, how did we get here in this short period of time? How did we get here, and how can we begin to think about changing? I study the history of racism in public health and medicine. So in the next few minutes, I'm going to sketch very broadly and quite briefly how racism got so deeply embedded in the history of medicine and public health. I'll engage with just a few authors, both contemporary and from the past, to illustrate the importance of history to better understanding health and disease. And that might seem a bit counterintuitive to some of you, and I hope I'll make it clear why history is important. In 2016, public health scholar Rachel Hardiman and her colleagues published an article in the New England Journal of Medicine, a prominent medical journal in the US, that connected the health effects of police violence to the many other dimensions of structural racism that are now under investigation in medicine and public health. In this article, they define structural racism broadly, and to my mind, really quite helpfully, as quote, a confluence of institutions, culture, history, ideologies, and codified practices that both generate and perpetuate inequity among racial and ethnic groups, end of quote. The issue that they are arguing we need to address is, one, how and why has inequity been produced in the first place over time? And how and why has inequity persisted such that we're still asking the same questions that we were more than a century ago? A few days ago, medical historian Aya Nuruddin published in Lancet, a journal out of the UK, a historical analysis of, and I quote, how the histories of violence, neglect, and oppression that crisscross law enforcement, politics, medical care, and public health are inextricably linked and manifested in the present. So two authors about 4 years apart, addressing the same issue and problem in slightly different ways. Interesting, Hardiman and colleague called for teaching history to students in all the health professions. While some medical schools and public health schools nationally and globally, including Alpert Medical School at Brown, are starting to teach some history, we all have a long way to go to figure out how to do this really well. How do we integrate history into the medical and public health curricula that hasn't historically had history? My panelists know much more about COVID, and I'm sure COVID will come up in the Q&A than I do, but let me just say the high morbidity and mortality occurring among Black people from COVID-19, such as the 70 to 80% death rates in cities like Tulane, Detroit, Milwaukee, and so on, to cite just a few statistics, has been greeted with shock, if not outrage, by at least some of the general public. But Black communities live such statistics, and they have lived with these statistics for centuries. The experience of COVID is then nothing new. And it wasn't an accident that COVID hit Black communities so hard, as Ron has just mentioned. It is encouraging that there's more focus on structural racism in medicine and public health than at any time in the past. Yet our understandings of why Black communities have been so profoundly affected remains actually superficial 8 months into the pandemic on the East Coast. And let me just give one quick example. The language of, quote, underlying conditions is kind of thrown out there in a routinized and racialized way, such that it really fails to capture the lived reality of health, and it obscures the lived reality of health. So our language, it's shorthand for lots of reasons, but we have to pay a lot more attention to it. So our task then is to tease apart how the social order, as Hardiman and both Nuruddin pointed to, has so profoundly damaged health of Black communities in this country. Before going on to mention some fairly bleak history, I do want to say that I'm cautiously optimistic about the current moment. If we acknowledge this history, and if we accept different ways of analyzing health. The Tuskegee study of untreated syphilis in males is a well-known and embarrassing moment in the history of public health. And really, moment is a misnomer because the Tuskegee study went on for 40 years and it was published in the most prestigious public health journals. However, what I want to emphasize and I can't begin to really go into it here today, but the roots of racism in medicine and public health go much, much deeper than Tuskegee. Dating to 1899, to give just one example, when famed Black intellectual W.E.B. Du Bois wrote his brilliant study, The Philadelphia Negro, a social study, Du Bois showed that the causes of poor health among African Americans were, quote, largely a matter of conditions of life. And so, he argued, solutions will be found by changing those conditions of life, not in the search for biological genetic difference. In this work, Du Bois clearly laid out the details of how poor health related to conditions of life for formerly enslaved people in the US. And for Du Bois, not only was poor health not due to innate biological difference, nor to personal behavior, but it was neglect in the aftermath of the failure of Reconstruction. So at that moment, Du Bois was introducing the history of the US and of white supremacy that we have yet to fully engage with. More than a century later, in fact, Evelyn Hammonds was still critiquing the straw men of biological difference, as were numerous other authors such as Troy Duster, Sam Roberts, Deirdre Cooper Owens, and Raina Hogarth, to mention just a few. They all have tracked the history of biological explanations and theories of personal behavior in ways that have obscured the causality of poor health. I might just mention that this was a moment when the idea of race correction of lung function measurements, now built into the spirometer, a medical device that measures lung capacity, as I've written about, and which Du Bois in the late 1890s actually contested, became solidified such that race correction is still the normative practice in diagnostic measurements for respiratory diseases. That shocks many people, but it's built into all the machines. Even when the utter inadequate access to healthcare has been exposed with COVID, we still encounter more and more interest in exploring biological explanations for higher rates of COVID in Black communities. I was shocked when I first started seeing papers like this, but it continues. Let me conclude by highlighting the work of David Williams, professor of Africana Studies and Public Health at Harvard, who in 2001 wrote what to my mind is a really path-breaking article entitled Racial Segregation, a Fundamental Cause of Racial Disparities in Health. And it provides us guidance for what we need as a society to do. Williams writes, quote, racial segregation is a primary cause of racial differences in socioeconomic status by determining access to education and employment opportunities. SES, in turn, remains a fundamental cause of racial difference in health. Segregation also creates conditions inimical to health in the social and physical environment. So the solution is kind of obvious in segregation. Thus, to the question posed to the panel, why is Black health so poor and what are the causes? My honest answer would be that we don't have a really good understanding because we have not asked the question in ways that will give us answers as to how neglect became so normal to and structured into the practice of medicine and public health, such that it's invisible to experts studying diseases. As Troy Duster has told us long ago, we only get answers to questions that we ask. My students hear that endlessly, but I think it's one of the most profound statements that I've encountered in my career. When ideas are deeply entrenched in medicine and public health and in society, of course, it's difficult to root them out. It's difficult to see. In other words, returning to Hardiman and colleagues, to disrupt this history and particularly disrupt its perpetuation, we have to recognize it, and then probe how it works. Thank you very much.
Thank you, Professor Braun. Next, we'll have Professor Akila Doolan, who is in the School of Public Health and Department of Behavioral and Social Sciences. Thank you, Dr. Doolan.
Thank you, Dr. Albert. First, I'd like to thank Dr. Rose and Provost Locke for the opportunity to be able to join my wonderful and esteemed colleagues on this panel to talk about race and public health. And so I'm going to spend the next 10 minutes or so talking about some of the research and policy work that I'm doing currently. If you'll bear with me, I do plan to try to talk about 2 topics. Initially, I proposed 3, but that might be a bit ambitious. So I'm only going to talk about 2 and perhaps the third if we have time. But I'm going to discuss some of the research that I'm doing with colleagues around the idea of resilience resources and HIV among African Americans living in the South, as well as a lot of the policy work that I'm doing currently that are both of these areas of work for me are really being shaped by the current climate. And I really think that it's important for me especially, to communicate to all of you about these 2 topics, because the current events in the US have really shaped and pushed me to think more critically about how the lived experiences and the social and structural factors that, such as structural racism, that contribute to the lived experiences of African Americans is really affecting how I think about the work that I'm doing, how I interpret the work that I'm doing, how I disseminate that work, and how it's conveyed or understood by both academic and lay audiences. So I'll actually probably end each segment of my talk with a couple of musings, because I don't have the answers, but I do want to share some of the critical thinking and current concerns that I have around these topics. And so the first thing I'm going to talk to you about is this idea of resilience resources and HIV really taking an asset-based approach to health. So in 2015, a colleague at Brown, who's Dr. Chanel Howe, and I really wanted to come together and think about how we could do some work collaboratively. She is in the epidemiology department and has very strong depth of expertise in racial health disparities, methods, and HIV. And I bring to the table experience and expertise in social determinants, community engaged research, as well as measured development and health disparities. And independently and jointly, it became clear that, of course, we would do something around African American health disparities as a collaborative effort, but that we really didn't want to focus solely on health disparities or this deficit or risk-based approach that really asks, what are African Americans doing wrong? And how are engagement in these risk factors contributing to health disparities? We wanted to reframe the question and shift the focus to ask, what are people doing, what are African Americans doing right? How are they able to engage favorably with their HIV care to have not ideal outcomes, but successful outcomes, such as being virally suppressed, attending their visits, and engaging in medication adherence in spite of the real structural level barriers that they encounter in their daily lives. And so we centered on this idea of resilience, and basically at its most basic level, resilience asks, resilience is basically the idea of overcoming life's adversities or thriving or flourishing in the face of those. And what we decided is that we really wanted to think about resilience from a multi-level perspective and not just focus on resilience resources within the individual, but what are some of the external resilience resources that they're utilizing? So, for example, family resources or community resources that help them overcome these very real structural barriers to continue to engage favorably with their HIV care. What we did know is that there was a lack of research in this area, specifically with African Americans. And often we haven't asked what African Americans are doing right. I mean, health disparities work does have its merits and its worth, and it's a valid area of research to pursue. But sometimes we need to reframe the debate or focus on other aspects. We also knew that it was important to identify this subset of African Americans who were resilient with regards to HIV outcomes, as well as hear directly from them specifically what resilience resources they're able to draw upon. And so armed with these research topics or research question in mind, Chanel Howe and I submitted an NIH grant proposal. I shouldn't say like one. We submitted multiple proposals, and I think that was a test to our own resilience resources and our reserve capacity, because eventually we persevered and we were able to get this funding to do this very critically important work. And what that led to is a series of a three-phase research approach, but I'll only focus on the first phase, and the publication is included below. But what we did is we hosted a series of meetings, small group meetings with African Americans living in the South who are also living with HIV, who demonstrated these favorable HIV outcomes. And we asked them these questions, in spite of ongoing life challenges, what is it about you that helps you overcome them? What resources do you draw upon from your family, from your friends, from your community that helps you overcome these challenges so that you're able to favorably engage in care? And the response from participants was just overwhelming in a positive way. And they provided so many thoughts and ideas around the resilience resources that they're able to utilize. And I've listed some themes here for all of you. So thinking about neighborhood healthcare and policy resources. So for example, they talked about the idea of just neighborhood aesthetics, neighborhood order. So having some cleanliness in the neighborhood, having social support in the neighborhood, healthcare resources, such as the idea that there was no stigma in the clinic, that they were treated with kindness and compassion around their HIV care and just them as a person, and policy level resources, such as the availability of programs like Brian White and those that support medication, being able to obtain needed medications. The family and friend resources really centered around the ideas of social support, so emotional social support, but also instrumental social support. And person level factors included things such as the idea of acceptance, not having any stigma around living with HIV, accepting an HIV diagnosis, and not having any shame around HIV. And prior to this series of structurally racist events that have continued to go, just that don't seem to have an end in sight. And I was very buoyed by this idea of resilience resources. But with the events that we've seen nationally, coupled with COVID, it's really pushed me to switch my thinking just a tad bit and ask about resiliency at what cost. So we're asking a subset of people to be extremely resilient in the face of enduring and unending chronic stressors, and at what cost does that have on someone's health and well-being and their outcomes? African Americans specifically demonstrate resilience on a surface level, but it comes at a cost to one's health and well-being. And that's a thread that I want to pull and explore a bit more and be more thoughtful about as I write these papers in response to the research findings that we have. And so I'll leave you with that thought, and that ongoing thread that I'm trying to pull, and the responsibility that we have as researchers to really convey the idea that resilience is a great area of research, but it also comes at cost. And while we're talking about or presenting this idea of resilience in health outcomes, that we also strive to change these real structural barriers that require some subgroups of the population to be more resilient than others. And that leads me to the last topic that I'll talk about just very briefly, which is the policy work that I'm doing as the chair of the Health Policy Committee for the Society of Behavioral Medicine. And this has been, I would say, one of my North Star for me during the current events. It's really helped keep me grounded and focused and feeling like I'm doing something to move the needle in changing some of these policy level factors that contribute to racial disparities in health. And I'll just leave you with a few examples of the work that we've pushed out as it relates to COVID. So thinking about specific actionable items for COVID-19 as it relates to healthcare, just racial health disparities, for example, in heat deaths during the COVID pandemic. And we also released a position statement on policing and structural racism and the need for further understanding and research in this area. And so I think I'm probably at time, and so I will stop there. And I'd like to thank you.
Thank you so much, Professor Doolin. Our next speaker really needs no introduction. I don't know when the person has time to sleep because they are on every news program on television, and they keep the busiest schedule of anyone I've ever seen. So without any further introduction, Dr. Ashish Jha, the Dean of the School of Public Health, Brown School of Public Health, welcome.
Ron, thank you. And big thanks to Professor Tricia Rose and her team and Provost Locke for organizing this extraordinarily important event. And it is difficult a little bit to follow both Professor Braun and Doolin, who I think have done a really good job laying out both the big picture as well as some specific areas. And I'm going to speak for just about 8-10 minutes and lay out from a public health perspective how I have come to understand and think about the intersections between race and public health. In 8 to 10 minutes, I can do no justice to this topic. There's so much complexity and important issues. So I'm going to highlight a few basic things, knowing that I'm probably going to leave a lot more important issues undiscussed that maybe we can get into in the conversation. So let's get to it. What we know when we think about structural racism in public health, there are lots of ways of measuring the effects of racism on the health of our population. And you can be reductionistic and start simply by looking just at key health metrics like infant mortality and maternal mortality and life expectancy overall and mortality rates at almost any age. And what you find is a very consistent pattern of higher mortality and lower life expectancy for Black Americans compared to white Americans. That has been the case for as long as we have been measuring these things and continues to be the case today. And it's difficult in some ways to just start with that because, of course, the factors that underlie it are multiple, and mortality is really kind of an end product of a whole set of things happening in people's lives and their lived experiences, their quality of life, et cetera. And I'm not going to unpack all of it, but I want to talk a little bit about why it is that we end up where we end up. And I want to really just mention 3 broad themes that I'm hoping we can get more into. The first is the way that structural racism ends up impacting the social determinants of health. So SDOH, social determinants, has gotten a lot of play in recent years, and they're pretty fundamentally important. So I'm a clinician. If I see a patient in front of me in clinic or in the hospital, the factors that drive that person's illness and lands them in front of me have a biological component, surely, but are largely driven by the environment around them. And when we think about the environment that affects people's health, long-standing practices and policies. I loved the definition that Professor Braun brought up of what is structural racism, and institutions, practices, culture, history, all of that, of course, have led to things like redlining, which has these profound effects on where people end up living. Where people end up living ends up having profound effects on what kind of air they breathe. And there is a long history of putting bus stops and bus depots in neighborhoods that have more African Americans and poorer people. And so these kind of environmental issues affect where people live affects the environmental issues, and all of that ends up having these profound confluences on people's health. And then you see them in the clinic and see people in the hospital, and it's really an end product of a whole series of policies that we have implemented that most physicians and nurses and frontline healthcare providers are blind to or don't consider and don't think about. So I think any efforts to make progress in these areas have to go back and understand both the history of how we have landed here, but also begin to address some of those underlying issues, because we can get better at therapies, we can get better at diagnostics. It will not be enough if we do not address the underlying factors that affect and have these profound effects on people's health. I want to shift a little bit to talking about a second issue, which I've done a lot of work on and thinking about, and that is about issues within the healthcare system itself. So I've started off telling you that factors outside of the healthcare system matter immensely, and they do. And again, things I want to address in the conversation that follows, but let's talk a little bit about the healthcare system itself. Until about 50 years ago, the healthcare system was explicitly segregated. And I say explicitly because exactly what I mean. Black patients got care at different hospitals than white patients did. And that was codified. And it was only in 1964, as Medicare was coming into being before the official legislation was passed, that the federal government essentially forced hospitals to become desegregated. Turns out policy is very important, and that was very important, but it did not end segregation overnight. And even today, we can see the legacy of that when we look at the fact that about 5% of US hospitals care for about 50% of all Black patients. And once you get to about 20% of hospitals, you're at about 80 to 90% of all Black patients, meaning about 80% of hospitals in America rarely see somebody who's Black. And so the healthcare system remains deeply segregated, even though the policies that led to that segregation are at least officially no longer on the books. And yet the effects of that segregation, of course, are quite profound, right? In terms of payment policies to hospitals and how we set up those payment policies and which hospitals get penalties and which hospitals get bonuses. It turns out in a lot of the policies we've implemented, including policies that were part of the Affordable Care Act, and it's an area where I was involved in doing a lot of work, when it came to things like value-based care and how that was structured, it largely ended up giving bonuses to hospitals that disproportionately cared for white and wealthy people, and ended up penalizing hospitals that disproportionately cared for Black and Latino patients. That wasn't the intention of those programs, but it was entirely predictable if you understood the broader social context in which people live and the care of individuals in those contexts and which hospitals care for which people. And if you understood that care is deeply segregated, those things I think were entirely predictable. And yet here we are. And a lot of us have been working both on the research side, but also on the policy side to try to undo and mitigate some of those harmful effects, born out of perfectly good policies, or perfectly well-intentioned policies, I should say. And by the way, that is actually probably the history of a lot of health policy in the United States. Certainly in the last 50 years, a lot of well-intentioned policies that end up, because they don't take into account these underlying structural issues, exacerbating exactly the problems that they think they're trying to address. The last part I want to just spend a couple of minutes talking about is issues around trust and knowledge among both in the African American community, and again, Professor Braun brought up Tuskegee. Tuskegee, I love her line, it's not a single event, it was a 40-year debacle, 40-year travesty. Think about the generations of people, investigators who were involved in Tuskegee. It wasn't one person's failure. It's probably one of the best examples of systemic blindness to what was happening. But it isn't the only one. And it has therefore, I believe, bred a level of distrust that ends up making the healthcare experience very different for Black Americans than it is for whites. And that distrust is not without reason. And one of the areas that I think the healthcare system has done a wholly inadequate job of is confronting that distrust, understanding the factors that underlie it, and deal with it. Another area where I think the healthcare system has done not nearly enough is in ingrained biases in the training of physicians and nurses. And here, there are some very visible, egregious examples that I think continue to persist today. So if you talk to most doctors and nurses, they will tell you the standard line that they are not racist. Okay, fine. The fact is that obviously there are these systemic issues that I have laid out, but there are also individual practices that I think question that belief that we are individually not racist. There is very good evidence, for instance, that when a Black patient is brought into the emergency department with a long bone fracture, these are very painful fractures of leg or arm, they're much less likely to get treated with pain medicines, much less likely to be treated with narcotics. And when physicians are confronted with that, you still hear, and it almost pains me to say this, but I will, physicians saying, well, the pain threshold for Black patients is different. That idea, that pernicious idea, comes straight out from slavery. And yet it continues to show up in how physicians and nurses think about taking care of patients. So that is a classic example of systemic racism that has persisted and continues to shape how physicians and nurses think today. So the task in front of us is enormous, and the challenge is enormous. I want to quote one of my heroes in this field, Dr. David Satcher, who was a former Surgeon General of the United States, and I had the honor of being on a panel with him not that long ago, and we were discussing the way the healthcare system exacerbates disparities. And he said, and again, he said it so well, and I'm going to try to get the wording right, but basically he said, in the great inequities that we have in our society, we had always hoped that the healthcare system would play a helpful role in closing and bridging those inequities. But time and time again, we see that it actually ends up exacerbating them. So I think the challenge for those of us in the medical field and in the public health field is not just to understand the underlying issues, some of which I've touched on, many of which I think were touched on more eloquently by Professors Braun and Doolin, but to confront that fact that we are part of the problem, not part of the solution. In the healthcare system and in the public health world, we can't fix everything, but we have to start becoming part of the solution. So let me stop with that and just say thank you again for inviting me to be a part of this, and I look forward to what I know will be a really fruitful discussion. Back to you.
Thank you, Dr. Ja. This opens up the session for questions, but I'm going to start with the first one. Professor Braun, you started with introducing this notion of how there's a historical context for how race is conceptualized and works its way into medicine. I know you've done some work with both spirometry as well as renal function. So I wanted to just raise the question of how these are not necessarily, I mean, you make the argument these are not necessarily biological factors. These are really historical factors that have worked their way into becoming perceived as a biological phenomenon. And then Dr. Ja, you sort of brought it up again in your remarks when you talked about pain thresholds and pain management. So I just wanted to put the question out there. How do we begin to undo some of that? Because it sort of perpetuates these stereotypes and these conceptions of race as a biological factor, and it sort of dismisses the social determinants that was so eloquently described earlier.
I mean, I think the beauty actually of Rachel Hardiman's paper, and then I think it's followed up quite nicely by Aya Nuruddin's, is that it offers many different places for us to work in. No one, and I try to tell this I teach medical students as well as undergraduates on this topic, and I try to, because it can be overwhelming. It could be utterly overwhelming. And the danger of getting overwhelmed is you give up. You say, I'm going to go back to my home, I'll earn my decent living, and I can't do all this. But the definition of structural racism offers us ways in that vary, and ideally, I'm very interested in codified practices, so I'm very interested in the subtle ways that racism gets in and perpetuated, rather than the explicit, not that one's more important than the other. So I think actually spirometry or kidney function, I also wrote on fetal growth curves. I mean, the algorithms are just popping out every day. And it shows how deeply entrenched, but then very different histories. So kidney function has quite a different history. A race correction of kidney function is a very different history than race correction of spirometry. Spirometry is goes straight back to Thomas Jefferson. And I didn't expect to see that, but that Thomas Jefferson wrote about pulmonary dysfunction. So what I think, I don't know if I've sort of wandered from your question, but what I think can be helpful is actually looking at history is how does it work at any moment in time? And then why is it then so normalized, as we've heard from, as all the panelists have addressed. So, I mean, I'll just turn it over to another panelist right now, but I could obviously go on. And I think that the very important point that Dr. Doolin is saying is African-American communities have been resilient forever. And they've been taking care of themselves, and really, a very wonderful book, Body and Soul, that Alondra Nelson wrote, recounts that history. And so that is part of it. But as she said, we can't, there's a cost, and the society should be bearing the cost, not African-American communities.
Dr. Jha, you just want to briefly touch on, follow up with this question as it relates to the practice of medicine.
Yeah, there's so many of these things, these kind of things that show up on the clinical wards when I'll be rounding with the team, and and even in every single laboratory result that you look at, it gives you a creatinine. I'm just going to pick on creatinine because I look at it every day when I'm on the hospital wards, and it says this is what it means for everybody else, and this is what it means for African Americans. And so, and I won't tell this which specific health system, but one of my closest colleagues and friends, one day, he's a pretty senior guy in this very large health system that I won't mention in Eastern Massachusetts, who just decided he was totally fed up with this, and first figured out what's the scientific basis, and it's pretty weak to start with, if there is any at all, and just decided just to get rid of it. And it was this uproar in the nephrology community. People were like, "Oh, we're trying to provide evidence-based, customized care." And you realize, no, first of all, there's very little scientific basis. And the second, it creates this sort of biological model for race that just doesn't function very well in clinical practice. And so part of it for me, as I watched him go through that experience, get the pushback, stay strong, and has managed to move this forward, is we have to go back and re-examine every one of these things and ask, is there really any basis for it? And I'll tell you where my bias is. There's little to no basis for any of this stuff that we have created as kind of biological markers around race. And the presumption should be that it's bogus unless there is very compelling scientific evidence, not the other way around of the presumption is this is real, and then we have to spend all this time trying to prove that it's not. So I think medicine needs to take a kind of very hard look at itself on this and begin by removing all of this. And then if there is some unlikely reason that we have to put it back in, I'm open to that discussion. But I think we've got the default setting wrong here.
Thank you. Questions to start this question with Tequila or Professor Doolin. This is from one of the panelists, from one of the participants, who says, "I would love to hear about what we can do as researchers and educators to improve health disparities and build upon the resilience in communities of color." Big question, but would love to hear your thoughts.
Thank you for the question. Thank you, audience member. So the first thing that I want to talk about is this responsibility I think we have as health disparities researchers to present our data in a more meaningful and contextual way. I'm struck by how we do start many of our papers talking about African Americans are 2.5 times more likely to have this disease relative to other groups. And that message gets distilled out and separated from context. So it reifies potentially this idea that there are real racial and biological differences. If we just added some additional context to even that one sentence, where we say African Americans are 2.5 times more likely to have this health disparity, which is largely driven in part by the adverse social determinants of health, I think that adds more context, and we have a responsibility to do so and think more thoughtfully about how we present our health disparities data in a much more nuanced and full way to really give more attention to those social determinants of health in our writing and our practice. And I think that answers the first part of the question. Could you please repeat the second half for me?
How do we build upon resilience in communities of color? How do we build upon that, citing the work that you've done and maybe others, to maybe perhaps also include other communities as well?
So that's the ultimate goal of the work that we're doing in the context of HIV. But really, this resilience building requires that we engage communities directly in the entire process of intervention building and development so that there's collaboration and buy-in throughout the entire process. And hopefully using that kind of an approach can also build sustainability. And just being very open and transparent and engaging communities, not just as, you know, participants in research, but as research partners. And I think that if we are training a cadre of practitioners and public health researchers to think along the lines of communities as partners and in doing more community engagement along the way and being trained in community engagement, I think that will go a long way.
There's a question from a panelist who points out that they are from a participant, they are a Doc Brown graduate working on their 6th reservation. They wanted to make the point that we should really highlight and bring up more attention to some of the healthcare disparities on reservations, particularly in this time of COVID.
And I'm not an expert on the care that Native Americans have gotten in America in the last several hundred years. I will say a few things about that in general, and then talk about what's been happening with COVID. Disparities in health outcomes for Native Americans are shocking in terms of the differences that we see. And again, a lot of it is everything from the way we fund Indian Health Service to the way that sort of broader social context in those communities, what the U.S. government has done. So this is an area where almost every health outcome you look at, it's dramatically worse for Native Americans, especially those who live on reservations. In terms of this pandemic, we have seen much of the same set of issues play out that we have seen for other communities, right? So if you, again, I don't want to get too much into disparities in COVID, though it's hard not to talk about it a little bit. If you think about what are the major themes that have created these disparities, they're all of the social factors that we've talked about, which we can delve more into. But there's also just simple, basic stuff, like where did we put up testing centers? Testing is a really fundamental part of identifying people who are infected. Guess where they were set up? They were not set up, certainly weren't set up based on risk. They weren't even set up kind of equally across communities. They were set up in places that were relatively low risk. And so the diagnosis happened later, more people got infected and sick. And that has been a pattern that has first showed up really in the African American community, then has been seen in the Latino community in Texas and Florida, and we've also seen this with Native Americans on the reservation. So it's been a pretty consistent pattern, and the outcomes have been pretty consistently much, much worse. I don't know, I'm happy to get more into it, but at a high level, I think those are the issues.
That's great, thank you. I'm going to combine a couple of questions here. The first part of the question says that, do you think that doctors and nurses are getting enough training on microaggressions and other forms of systemic racism? Often the way a person looks when they are admitted drastically affects the care that they receive. Related to that, I also want to add to that, what ways can patients of color advocate for themselves to help overcome some of the systemic discrepancies that they receive in care? So I'll put that to the panel. You can start, Dr. Ja, with respect to the training of medical staff.
So I would say the short answer is no, and I'd be really curious what Professor Braun, who trains medical students even more than I do, much more than I do, thinks on this. But on the issue of medical training, I think race and racism and the social factors that drive these large inequities often get relegated to one single module of one kind of social factors in clinical medicine course and get covered pretty superficially in lots of medical schools. And so it is little doubt that future physicians get a kind of a very, I think, simplistic understanding of what the underlying factors are, and then are not really able to incorporate those into their clinical practice. So I believe, and there's always pressure on what do you want to teach medical students, and I'm sympathetic to arguments that say we need to teach them medicine. That is true, but we need to teach them how to practice medicine effectively, and that necessarily means spending more time and effort teaching them the broader context in which medicine is being practiced.
Very quickly, like to add in terms of medicine, and then I think what's going on in public health curricula is different. But I have to say, I think there's been major changes in some medical schools in this country in the last few years. So at Brown, for at least 7 years, students have been contesting the presentation of disparities without context, as Dr. Doolan was just talking about. And that has been addressed, not always perfectly, but I think there is on the part of the Office of Medical Education a real attempt to listen and make trade-offs. I mean, I think we could even think of this as medicine, this is deeply, the idea of structures and how racism work is deeply intertwined and is medicine. But I do, a new competency at the med school now is teaching history of racism. And students have been at the forefront, including across the country around kidney function abolished, including at the Lifespan Hospital. Dr. Grissom was a major figure in doing that. So I said I was cautiously optimistic, and that's based on a lot of what medical students are asking for. That said, there's so far to go, just really far to go. The experience for students of color is still a very alienating one. But the data on pain was done at a medical school, and I won't mention the medical school, but it's very easy to figure out from reading the paper published a couple of years ago. I mean, we've known this for a long time, but that did trigger some efforts for change.
Dr. Doolan, this is specifically for you. Do you have any practical ideas that you can offer about how to use the evidence of resiliency in clinical practice routines and in teaching current medical students?
That is a great question, and one that I'm a little bit stumped by. So I'd actually have to think about that a bit more. I don't teach in the medical school, or I have very little interaction with the medical students. So I'm not sure specifically what their curriculum looks like or their level of understanding about the idea of resilience or how that might look in the clinic. The one thing that I do know is that there's been a push for clinicians and providers to measure or ask their patients about the social determinants of health, and then connect them to referrals to address some of those social care related needs, the non-medical social care needs that subset of the population may need. But one of the concerns that comes up in that particular process is the idea of that reinforcing physician bias about the patients with whom they serve, and how are they able to effectively communicate or address those social determinants. So I kind of flipped the question, but I think that also warrants consideration.
Along with policy changes and updating medical training, it seems getting more people of color into public health and medicine is critical. How do we inspire young people and give them support through their educational lives so they can end up working in these fields?
This is $64,000 question. It's a pretty critical question. whether it's physicians and nurses, and again, especially in the medical field among physicians, the proportion of physicians who are Black, for instance, has risen a very tiny amount over the last 30 years. And it's just sort of shocking how little progress we've made there. When I think about public health, one of the things I often point out is that while there is greater diversity among public health practitioners, when I look at the leadership of public health in the United States, it's almost all white. And so we really do have to take a very concerted effort to change this. And my sense is that the problem here is not a lack of interest. It's not a lack of capability. It's clearly about opportunity. It's about environment and creating the right context and supporting people through that process. So obviously just a month into my new job, but been working with our team to say this has got to be our top priority, to change the face of public health leadership in the United States over the next generation. I think it's entirely doable. I think it's doable if we, again, both create the right environment, change how we think about the folks we engage with and interact with. And it's going to end up being it has to be a priority, I think, of all public health schools across the country. It shouldn't just be one for Brown. So,
well, I appreciate you shifting the focus from, because most of the questions have come in have been fairly medical focused, but I think one of the things that this pandemic has demonstrated to us is how fragile and how fractured our public health response has been. And so I like the idea of you shifting it back to public health, because it just seems to me there is a lot of opportunities for us to improve our public health infrastructure, which includes, world-renowned agencies like the Center for Disease Control, the FDA. We're under siege right now. Yep. And there really needs to be concerted efforts to create a next generation of leaders to take over those institutions and bring them back to the austerity that they had, or the sort of stellar reputations they had in years past. Any other contribution to that part of the conversation, either Dr. Doolin or
Yes.
Dr.
I'd like to say that we could leverage existing best practice programs. So Brown University has the Leadership Alliance that brings in diverse scholars over the summer and pairs them with professors in the practice of research. And we've had some come through our School of Public Health, and perhaps we can cultivate more students that way. We can leverage our existing partnership with Tougaloo, which I know our School of Public Health is doing, and creating more opportunities for Tougaloo students to come directly to join our program as master's level students. We could also leverage existing TRIO programs such as the Ronald McNair program, which I actually was a part of during my undergraduate years, that trained me how to do research and science and gave me that opportunity. And for us who are researchers, we can also leverage the National Institutes of Health pipeline programs that provide diversity supplements for students as young as in high school. So just taking advantage of those existing resources in a more concerted and systematic way could definitely change the landscape of our public health profession.
Do we have to recreate our healthcare system in order for everyone to receive equitable care? And I guess related to that is, will that really safeguard us against some of the recreation of the healthcare system? I guess they're probably referring to a single payer. Will that really safeguard against some of the disparities that we've seen under the current healthcare system?
When you look at COVID outcomes, I'm begin with COVID, but I can go into a broad set of issues, and look at disparities in outcomes by race, ethnicity. They're about equally large in the UK as they are in the United States and the United Kingdom. I'm talking about primarily England, and obviously the UK has a National Health Service with not just a single payer system, but a single provider system. So what I want to make sure that we don't get lulled into is thinking that there is an easy fix, that we change how we pay for healthcare. Instead of Medicare for people over 65, we go to Medicare for all, and somehow the disparities will go away. Now, there's no doubt in my mind that we need to have universal health coverage and everybody needs to be covered. There are lots of mechanisms for doing that. But I want to make sure that we don't see, there are no panaceas. It's just a whole series of hard work on a lot of issues. These are issues that have been with us for hundreds of years. And as much as I very much support efforts to get us to 100% coverage for all Americans, I think that's fundamental. And I think that'll help and it'll make a difference. I am unconvinced that that represents a game changer for disparities in health.
If you could speak about the characteristics of neighborhoods and housing that are most important for the reduction of health disparities, or that's the question, but I suppose you can turn that.
I think that someone asked that question, and that's a softball question to me because I teach the Place Matters course in public health. That was not a planned question, I promise. So
It's cousin of Dr. Doolin. Oh, no, just kidding.
I think the idea of segregation and removing those kinds of barriers is important, but it's what does racial segregation actually mean? That's the issue. When we talk about health disparities based on segregation, we're really talking about the disparities in resources, intentional disparities in resource access shaped by neighborhood racial composition. And so if we want to move the needle on place-based disparities, we also need to institute place-based initiatives that support health promoting infrastructure and resources paired with cultural change and shifts in behavior, as well as instituting some kind of a plan. The grand plan is how do you create these structural level changes without promoting gentrification or the residents who you're trying to help getting pushed out in the first place. So it's going to take a lot of strategic, intentional thought about the policy, the targeted policies in these specific neighborhoods and what they might look like. And we had initially policies like Hope 6 that provided mixed income housing or tried to remediate urban blight. We also had promise and choice neighborhoods that were much more community driven. And now we have these policies in place. I don't know if it's choice or promise neighborhoods, but there's always this underlying undercurrent of communities being revitalized to a certain extent that those communities get pushed out. So how can we keep those communities in place and deliver those kinds of place-based services and allow them to remain at home? We also need to think about the idea of affordable housing and the quality of housing stock, because so many asthma disparities, for example, are driven by poor environmental toxicant exposures, as well as within home environmental quality. So that remediation needs to take place as well.
Another question, studying and working at an Ivy League institution brings with it certain privileges. What advice do you have for students and employees who may identify as historically underrepresented and or from low-income backgrounds who find themselves with a gaining and theoretical understanding of these disparities, but still have one foot in a world where these inequities are occurring daily, family members getting poor care, and also another foot in this this institution of privilege?
I don't think I'm the person to tell historically underrepresented groups how to deal with the privilege at Brown. It works in profound ways, and it can be very undermining, and it's exhausting because you are often, and I've seen this with medical students for years and years and years, dealing with family situations that other people don't have to deal with. And how that gets navigated is really challenging and needs role models. I mean, plain and simple. And we need more faculty, Black and Latinx faculty at the medical school, I think, to even begin to address those issues for medical students. But I'll defer to other panelists on this.
So my advice has been typically very old school, traditional. I've been in the same boat, right? And so this very idea of we want to do something as undergraduate students or graduate students, and the advice given to us for so long, and the advice that I've actually echoed and parroted, is that the most effective way that you can be helpful at this stage is getting your degree, so that you can make the maximum impact and have people actually listen to you. Now, given current COVID pandemic and current unending structural racism, that seems very cavalier advice. What I would say, what has been helpful to me is having a support group of my peers who I can talk to about these kinds of issues. There is, I've called other faculty members in the middle of the night to talk about the issues of structural racism when it just became too much and feeling ineffective and disempowered. And so having that large support network has been very helpful. And also thinking about how my research in some small way is addressing this issue or trying to move the needle forward or advocating. I think this generation of students is very different because you all want to marry the idea of research and advocacy. I would encourage you to continue to do both, but just put some boundaries on it because you don't want to get burned out.
For the foreseeable future, the doctors caring for Black, Indigenous, and Latinx patients will remain overwhelmingly white. What will it take to improve care today?
There is little doubt that we need a far more diverse physician workforce. Let's just talk about physicians for a second, because that's where the questioner sort of pointed. There's no doubt. And that is the work. Again, we have made far too little progress on this. And I think we need to go back and think about why have we made so little progress? As we have been thinking about diversifying our own faculty at the School of Public Health, it's been really clear to all of us as we look at it is whatever we've been doing for the last 5 years, we need to take a new approach because it isn't getting us there fast enough. So I think the same thing has to happen in medicine where our efforts are again, I'm not trying to downgrade or denigrate the efforts we've made, but we've got to, I think, do it differently and more aggressively and better. But the bottom line is we're never going to get to a society where everybody's taken care of by somebody who looks like them,
Sure.
or has similar experience. And we've got to focus on training physicians to understand people's contexts, their lived experiences in a very different way so that physicians will still bring their own personal experience to it. There's no way to avoid that. And I'm not even sure that we always want to eliminate that. But teaching people how to think outside of their own personal experience to understand other people's perspectives, it's got to be a pretty central part of medical training, but it also can't end with medical training. So I think we have to think about how do we take the million or so physicians, about 900,000 physicians who are already out in the workforce, and how do we help them become more effective?
And I think that's the nature of the question. I think, Lundy, you might want to speak to this as well, given the work that you've been doing with the School of Medicine and the fellows, and the projects that they do around anti-racism. So you just want to comment on that a little bit, and maybe those are the kinds of things, those kinds of opportunities to evolve people's thinking and to train people about some of these issues during those formative years may be something that can be helpful. I don't know. You want to comment a little bit about what those activities are about?
Well, I mean, I will just make normally I'm fairly negative. So, and then I started thinking sort of what has happened and actually how problematic negativity can be too. And so I would say that certainly since the murder of George Floyd, Breonna Taylor, I mean, the murders that became highlighted, and there's a tragedy in that for what all the various police murders that have been masked, but I've seen phenomenal things happening in the medical school from the emergence. It's some people in various departments in the many of whom are in this working group that I've organized over the years and has become it's a working group in race, medicine, and social justice. And it was originally designed for humanities, social science, and medical collaborations, but it didn't have very many physicians. And now it's increasingly physicians. And they are then doing different things in the various, their own settings. The CPC, I always forget the name of it, the primary care clinic, the residency clinic at Lifespan, the emergency department, the medical department as a whole. There's a lot happening. Almost, I do think we're going to see some systematic approaches or disruptions. I think one of the Q&As asked about what's happening to disrupt. I think it's kind of grassroots, frankly. That's important. It has, obviously, major policy changes, but I am a big believer in the importance of grassroots work, almost like Dr. Doolin was talking about in terms of resilience and what she studied, what communities do for themselves. That is happening more in the medical school. Not to say things are perfect, but there's a lot that's happened this summer. It used to be impossible to use the term racism in publications, in teaching. You had to use bias. And now you can just talk about racism. And then you can, once you're actually naming racism, as Hardiman argues, you can begin to see how it works.
There have been a couple of questions about pipeline again, and focusing on some local activities in terms of Brown's responsibility to the public schools. What is the public health, what School of Public Health doing in the community to improve public schools and improving literacy? And I think there's also a comment by someone from the Swear Center that has outlined a number of activities that are happening around Providence and Rhode Island related to that. But it does. I like this idea of raising this question of pipeline, and we talked a little bit about that earlier. But when we often think about that, we're focused on, the college level already, or the professional development level. What could we be doing as an institution, as individuals, to actually, and this is a question somebody raised earlier, to think even further back to try and start to engage cohorts of young people. Certainly can start with our neighboring community. I think Professor Doolin mentioned a little bit about this in some of her remarks, but I just want to kind of put that back on the table again for us to maybe talk about in a general sense, but maybe something specific as well. So I just want to put that out there. You want to start, Professor Doolin?
Sure. So I'll say within the school level, some of us, we have a very strong partnership with the Rhode Island Department of Health. And I know of 2 ongoing high school dropout prevention programs where faculty are serving as the program evaluators. I am on one of those projects, and Dr. Dave Williams is on a similar project with girls. Prior to the pandemic, before the pandemic, and I guess we're all in the same space, but I had proposed to work very closely with a group of youngsters, young kids, young boys, to do a photo voice project around the issue of environmental toxicants in the south side of Providence. But given where we are with the current pandemic, I think that's been placed on hold. One of the things that we have done at the school is to support local community initiatives. And so I think maybe 2 years ago, we had the One Gun Gone community project, which was spearheaded by a group of young boys around art installations depicting the level of gun violence and how we can overcome gun violence more locally in Providence. So I think it's really pairing with community organizations. And another project led by Dr. Kim Gans was partnering with the Youth in Action group, who is a very active group of young students, around the issue of another photo voice project to catalog the food environment and thinking about ways we could intervene there. So identifying those local school driven organizations and initiatives and pairing with them and letting, again, it be a collaborative relationship.
But there was a comment that we that we did receive. The Swear Center has a lot of activities that involve the Providence community. So if people are looking for opportunities to volunteer or to do things that are local, that's a good place to start. Here's a question that asks, can we touch on maternal mortality rates and its impact on women of color? That's one that I think really sort of drives home this issue of structural racism as being a major factor for some of the disparities and disparate outcomes that we see in maternal mortality rates. Anybody want to start this? I'll start with you, Dean Jha.
Not an area I have deep expertise, or others who really have dedicated their careers and lives to studying this. And so let me say at a high level that when you look at pregnancy-related mortality rates for for African Americans particularly, it's about three and a half times what it is for white Americans. And that's a very, very large gap. And over the last 10 years, all the data suggests it's been getting worse, not better. Whenever you see, and I said this in my opening remarks, whenever you see an outcome difference like that, it's rarely one thing that explains it, right? So is it about access to care? Yes, it is. Is it about what kind of care providers you access and what their capabilities are? Yes, it is. Is it about where people live? It's all of those factors. And I think it needs to be taken apart. There is really good work being done on this. Just one other thing, and again, I don't want to talk more than what I really know about this. The impact of mortality, of women dying at childbirth, is hard to overstate. One of the big ways that we have made progress as humanity is lowering maternal mortality rates across the world, because it is devastating for families, obviously for children, for communities. And so I think the fact that this gap is as substantial as it is and that it is getting worse over time has really focused a lot of people on making this an urgent public health priority. But let me see if other folks who may know more about this than I do can comment.
Yeah, so I also want to just reiterate that this is one of those where it doesn't matter what level of income or education you're at, this differential still persists. And so, there's some high profile examples like Serena Williams and people like that who lots of what we think, well, they have lots of income and lots of stature, but still felt like she still expressed that her interaction with the healthcare system were less than desirable. So that's one of those where, and again, this gets back to some of the points you made earlier about these stereotypes around pain management and pain thresholds and that sort of thing, sort of transcend things like social class and income and all the things that we think sort of provide a buffer for some of these health disparities. So does Akilah or Lundy, you want to say anything more about that?
I'll just say, are you sure you don't want to say something, Akilah?
I'm sure, thank you.
Okay, it's so infuriating that it's worsening. And we've been paying attention to this as a topic, as a field of research for so long. And it's the fact that it's worsening, and we know that, it's just appalling statement of the healthcare system. Great
comments here today. I think one of the things that I want to, this issue is so vast. There's so many things we've left out. As all of you said at the beginning, this is something we're not going to resolve today. We're not going to come up with a solution today. But I think, given the nature of the time that we're in, it certainly gives us an opportunity to have more of these conversations and to try to strive to figure out what can we do going forward to make some of these ideas more actionable. And I think, as I said, there's been a lot of COVID questions that I wasn't able to get in, but there's I think the pandemic has really, as well as some of the events around the police actions across the country, has really sort of brought the country to confront these issues in a way that seems much more urgent. And hopefully, this won't be a moment, but this will be something that we are moving closer to having some real solutions around. The other thing that we didn't really touch on, it was raised by one of our members, one of the attendees, around what's happening on the reservations. We also, the Latinx community has been devastated by COVID-19 as well. There's a wonderful article in the New York Times this past weekend that talks about the experience of undocumented workers. And the line that I really like, the way that article ends, it says, we're all facing the same storm, but we're in different boats. And so I think we need to, I'm looking forward to having, participating in more parts of the series, and also to having more discussions and more engagement around these issues going forward. I guess the last thing that I would sort of raise to the panel is, are you hopeful about things going forward? And give us some reasons or some things that we might be able to look forward to. Starting with you, Lundy, since you have the mic.
Briefly reiterate what I said is I'm cautiously optimistic because of some of the steps in recognizing the problem, which has not been there. So whether we'll continue to hold on to it, I think, is a big question. It's up to all of us.
Dr. Doolin.
Hopeful given the current context we're in, or hopeful given changes and movement in how we understand race and public health research?
I would take the latter, because we're hoping to be out of the current situation we're in, hopefully soon.
I am not sure. I think we have a lot of work to do. I mean, there's a huge push to talk about racism as a public health issue. And I often wonder and worry that public health as it stands currently is not equipped to take that on. And does that also, that rebranding, push out the community organizations who've been on the ground doing this work all the time? So I'd actually like to ask that we hit a pause button on our efforts and get a little bit more introspection, self-reflection, and communication with communities and organizations who are doing the work. So I didn't answer your question, but that's how that's my thoughts.
I am cautiously optimistic for some of the reasons that actually Professor Braun initially laid out, that we can talk about this. We're talking about this as a nation much more openly, not just within academia. We see political leaders just calling it what it is: systemic racism, structural racism, in a way that we have not seen before. I do think there's a broader set of issues, and this gets at what Professor Doolin was talking about, which is that our society is going through, I think, some very profound changes, and will be for at least, I think, the next decade. I don't believe that what happened with the protests this summer was a one-off. I don't believe it goes away. I think we have moved into uncharted territory for our country, and uncharted territories are uncomfortable, but they lead to substantial changes. I don't believe that where we're going to be in 10 years is going to be incrementally better than where we are. I think there's a huge opportunity here. But where I want to go is what Professor Doolin said, which is, I'm not sure that the traditional schools of public health are perfectly equipped to manage this change. And one of the reasons I was so pleased to see Professor Rose take this on, make this one of the first things, is what I know is racism is profound. We see it. I see it in all sorts of places, and I'm confident I miss it in lots of places. And yet I am, as a public health practitioner, ill-equipped to think about and work through how these things affect public health. And so we're going to have to work well outside of our comfort zone with people we don't generally work with to take this on, both within the academy, but as Professor Doolin said, outside of the academy. So I just think that's a challenge for us. And I'm excited to take on that challenge and try to be a different public health school and try to be at a different university that's willing to do those things. But it's not going to be easy. but it gets me up in the morning and gets me going. So I'm happy to do it.
Thank you so much. Thank all the panelists who participated today. Thank you for the 800 plus attendees that we had registered for the event. And this concludes the day. Thank you.
Thank you, everybody.
Thank you, everyone.
Everybody, and thank you, Ron, for expert moderation.
You did a great job.
Thanks.